Syringomyelia is a rare neurological condition characterized by the formation of a fluid-filled cavity, or syrinx, within the spinal cord. This abnormal accumulation of cerebrospinal fluid can expand or elongate over time, leading to a range of symptoms such as numbness, weakness, pain, or even paralysis. The condition is often associated with other spinal abnormalities, but can also occur independently. In this video, we'll explore a unique case of syringomyelia, focusing on conservative management strategies and discuss the challenges faced by both patients and clinicians when dealing with this complex disorder. Let's begin by understanding the basics of syringomyelia and why it presents such a clinical challenge. Our case centers on a 68-year-old woman who experienced chronic back pain for many years. Her medical history included cervicalgia, lumbar radiculopathy, nerve root impingement, and degenerative disc disease. Despite various treatments, her pain persisted and even worsened over time. Eventually, an MRI revealed an incidental finding, a thoracic syrinx extending from T5 to T11. This discovery shifted the clinical focus and raised new questions about the best approach to her care. The rarity of isolated syringomyelia, especially without an underlying Chiari malformation, makes her case particularly noteworthy. Syringomyelia refers to a condition where a syrinx, or fluid-filled cavity, develops within the spinal cord. This cavity can disrupt normal nerve function, leading to a variety of neurological symptoms. The most common initial signs include sensory disturbances, such as pain or temperature changes. The severity and type of symptoms depend on the syrinx's size, location, and extent. Syringomyelia can be associated with Chiari malformation type I, but it may also result from trauma, infection, inflammation, or tumors. Understanding the underlying cause is crucial for determining the most effective management strategy. Syringomyelia can be classified into three main types: communicating, non-communicating, and extracanalicular. Communicating syringomyelia is connected to the fourth ventricle, while non-communicating is isolated within the spinal cord. Extracanalicular syrinxes, like in our patient, often develop after trauma and are found in specific regions of the spinal cord. These distinctions are important because they influence both the symptoms and the management approach. In this case, the patient's history of spinal trauma likely contributed to the formation of an extracanalicular syrinx. Syringomyelia is a rare disorder, with isolated cases, those not associated with Chiari malformation, being even less common. The prevalence of Chiari malformation type I ranges from 3 to 8 per 100,000 people, and syringomyelia is present in about 65% of these cases. However, isolated syringomyelia occurs in only a small fraction of the population. Advances in MRI technology have led to more incidental findings, including asymptomatic cases. This increase in detection has highlighted the need for clearer guidelines on managing patients who may not have classic symptoms. Patient's medical journey began with chronic neck and lower back pain, nerve impingement, and degenerative disc disease. She had a traumatic spinal injury in 2004, which set the stage for years of persistent discomfort. Over time, she tried various pain management strategies, including acetaminophen, ibuprofen, baclofen, and diclofenac. Despite these efforts, her pain remained difficult to control, leading to multiple emergency room visits and changes in her medication regimen. This complex history made it challenging to pinpoint the exact cause of her symptoms. As her pain worsened, the patient sought help in the emergency room for right lower quadrant abdominal pain radiating to her lower back. After ruling out acute abdominal issues, she was treated with a combination of medications, including prednisone, acetaminophen, and cyclobenzaprine. Despite these interventions, her pain persisted, prompting further visits and additional prescriptions such as lidocaine patches and oxycodone. These repeated ER visits highlight the complexity of managing chronic pain in patients with underlying spinal conditions. After her emergency room visits, the patient returned to the clinic for follow-up care. She continued to experience significant right-sided back pain radiating toward her abdomen, especially when tensing her abdominal muscles or changing positions. Pain relief was minimal, even with medication and heat therapy. At her next follow-up, muscle spasms were suspected, leading to new prescriptions including baclofen, diazepam, and ketorolac. Despite these changes, her pain persisted, prompting further investigation. Given the persistence of her symptoms, the patient was provisionally diagnosed with anterior cutaneous nerve entrapment and prescribed gabapentin for thoracic radiculopathy. An MRI was ordered to further investigate her symptoms. At her 2-month follow-up, she reported some improvement, but the MRI revealed an incidental finding, a thoracic syrinx spanning T5 to T11. This unexpected discovery shifted the clinical approach and led to a referral to neurosurgery for further evaluation. MRI of the thoracic spine revealed a syrinx extending from the T5 to T11 vertebral levels. This fluid-filled cavity within the spinal cord was not previously suspected based on her symptoms alone. The presence of a syrinx can explain many of her neurological complaints, including radiating pain and sensory changes. Imaging plays a crucial role in identifying such abnormalities, especially when symptoms are atypical or overlap with other spinal disorders. Patient's journey involved multiple diagnoses, treatments, and follow-up appointments over several years. The timeline of her clinical course helps illustrate the complexity of her case, from initial pain complaints and medication adjustments to the eventual discovery of syringomyelia. This timeline underscores the importance of thorough evaluation and the need for persistence in uncovering the true cause of chronic symptoms. Diagnosing syringomyelia can be challenging, especially when symptoms are atypical or overlap with other conditions. In this case, the patient's chronic pain and neurological symptoms initially pointed to other diagnoses, such as radiculopathy or even Parkinson's disease. Only after extensive imaging and evaluation was the syrinx identified. This highlights the need for a broad diagnostic approach and the value of advanced imaging techniques in uncovering rare conditions. Throughout her clinical course, the patient was evaluated for several possible conditions. These included idiopathic Parkinson's disease, Machado-Joseph disease, chronic pain syndrome, and radiculopathy. Each diagnosis was considered based on her evolving symptoms and imaging findings. Ultimately, the discovery of the syrinx provided a unifying explanation for many of her complaints, but only after other possibilities were carefully ruled out. Imaging, particularly MRI, is essential in diagnosing syringomyelia. Advanced techniques such as 3D constructive interference in steady state, CISS, and four-dimensional phase contrast, PC, MRI can provide detailed views of the spinal cord and syrinx. These tools help differentiate syringomyelia from other spinal pathologies and guide treatment decisions. In this case, imaging not only confirmed the presence of a syrinx, but also helped rule out other serious conditions. Once syringomyelia is diagnosed, clinicians must decide between surgical and conservative management. Surgery is typically reserved for patients with large, symptomatic syrinxes, underlying causes like chiari malformation or progressive neurological deficits. However, surgery carries risks such as hydrocephalus, meningitis, and persistent symptoms. In contrast, conservative management focuses on symptom control and quality of life, especially for patients with mild or stable symptoms. Conservative management of syringomyelia involves a multidisciplinary approach. Pain control is a primary goal, but conventional pain medications often provide limited relief for neuropathic pain. Alternative options, such as tricyclic antidepressants or antiepileptics, may be more effective. Physical therapy can also help improve function and quality of life. Behavioral modifications, like avoiding straining or neck flexion, can reduce symptoms by decreasing venous pressure in the spinal cord. Managing chronic pain in syringomyelia is often difficult. Standard analgesics like acetaminophen and ibuprofen may not address the neuropathic component of the pain. In this case, the patient tried several medications with limited success, even experiencing an accidental overdose from baclofen. This underscores the need for careful medication management and consideration of alternative therapies tailored to neuropathic pain. Physical therapy can play a significant role in managing syringomyelia-related symptoms. Exercises that improve mobility, strength, and posture may help reduce pain and enhance daily functioning. Additionally, lifestyle changes, such as avoiding activities that increase spinal pressure, can make a difference. While research on specific techniques is limited, individualized therapy plans are often beneficial for patients with chronic symptoms. Effective management of syringomyelia requires collaboration among primary care providers, neurosurgeons, pain specialists, and physical therapists. Each team member brings unique expertise to address the patient's complex needs. Regular communication and coordinated care plans are essential for optimizing outcomes and ensuring that all aspects of the patient's health are addressed. While surgery can be effective for some patients with syringomyelia, it carries significant risks. Complications may include acute hydrocephalus, bacterial or chemical meningitis, cerebrospinal fluid leaks, and persistent pain or sensory deficits. These potential outcomes must be carefully weighed against the expected benefits, especially in patients with mild or stable symptoms. After the incidental discovery of her syrinx, the patient continued conservative management with gabapentin and was referred to neurosurgery for further evaluation. At follow-up, her pain had improved somewhat, but ongoing monitoring was necessary to watch for any changes in symptoms or syrinx size. This approach reflects the importance of individualized care and regular reassessment in managing rare spinal cord disorders. Rarity of isolated syringomyelia means that there are few established guidelines for its management. Most recommendations are based on expert opinion or small case series. As more incidental cases are discovered through advanced imaging, the need for standardized care protocols becomes increasingly urgent. Research into effective physical therapy techniques and pain management strategies is especially needed. Educating patients about syringomyelia, its symptoms, and management options is crucial. Patients need to understand the potential for symptom progression and the importance of regular follow-up. Empowering patients with knowledge helps them participate actively in their care and make informed decisions about treatment options. Ongoing research is needed to better understand syringomyelia and develop effective management strategies. Studies focusing on conservative treatments, physical therapy, and novel pain management approaches could improve outcomes for patients with this rare condition. As more cases are identified, collaborative research efforts will be essential for advancing care and closing existing knowledge gaps. Summarize: syringomyelia is a rare spinal cord disorder that can cause significant neurological symptoms. Diagnosis often requires advanced imaging, and management decisions must be individualized based on symptom severity and underlying causes. Conservative management, including pain control and physical therapy, is appropriate for many patients, but ongoing research is needed to establish best practices. Multidisciplinary care and patient education are essential for optimizing outcomes. The case report was a collaborative effort among Kelly M. Skindle, Sabrina Bustos, and Susanna Villate-Prieto. Each author contributed to the concept, design, data analysis, manuscript drafting, and critical review. Their teamwork ensured a thorough and balanced presentation of this complex case, highlighting the importance of collaboration in advancing medical knowledge. All participants in this study provided informed consent for treatment and publication. The authors disclosed that no financial support was received for the work, and there were no conflicts of interest. Ethical conduct and transparency are essential in clinical research, ensuring that patient rights and scientific integrity are maintained throughout the process. Case report draws on a wide range of scientific literature, including studies on the pathophysiology, diagnosis, and management of syringomyelia. For those interested in learning more, the references provide valuable insights into current understanding and ongoing debates in the field. Continued reading and research are encouraged for clinicians and patients alike. Help visualize the patient's journey. The report includes several images and timelines that map out her symptoms, diagnostic workup, and treatment course. These visuals provide a clear overview of the complexity and progression of her case, making it easier to understand the challenges faced in managing syringomyelia. Conclusion: syringomyelia remains a challenging and rare condition, especially when it occurs without an obvious underlying cause. Conservative management, tailored to the individual's symptoms and needs, can offer meaningful relief and improve quality of life. As incidental findings become more common with advanced imaging, the medical community must work together to develop evidence-based guidelines and ensure that all patients receive the best possible care. Thank you for joining us on this journey through a complex case of syringomyelia.